Okay, so let's discuss the most common adrenal lesion, which is adrenal adenomas. About 5 to 10% are functional, most secreting cortisol, and more rarely aldosterone. The imaging features, they are usually small, less than 4 centimeters, usually homogeneous, well circumscribed, and the key feature is the presence of intratumoral lipid. So on CT, on non-contrast CT, adenomas will measure less than 10 Hounsfield units in about 2/3 of cases, and these are so-called lipid-rich adenomas. And this is, of course, because the presence of fat lowers the attenuation of the nodule such that it's less than 10. However, in 1/3 of cases, the attenuation is greater than 10 Hounsfield units, and these are so-called lipid-poor adenomas. This is an example. We would place our ROI, we get 3 Hounsfield units, and we can be confident that this is a lipid-rich adenoma. Now, for those lesions that measure greater than 10, we can perform washout CT. And it turns out that adenomas demonstrate rapid washout of IB contrast. Therefore, an absolute washout of greater than 60% or relative washout greater than 40% has moderate to high sensitivity and high specificity. However, note that these numbers are not 100%, and there are important exceptions to these rules, which we will discuss later. Moving on to MRI, adenomas generally have low or intermediate signal on T2 weighted images. Loss of signal or dropout on out-of-phase images compared to the in-phase is the key feature in diagnosing lipid-rich adenomas, again because of that microscopic fat. Now it's important to note that this feature has a higher sensitivity for intratumoral lipid than the 10 Hounsfield unit threshold on CT, and therefore MRI may be useful in cases where the unenhanced CT is just above 10 or 10 to 30 Hounsfield units. Now, how can you assess whether there's loss of signal on out-of-phase imaging? Well, most commonly we do this subjectively, and it's easy to appreciate that the lesion is getting darker on the out-of-phase. However, if you're unclear looking at it subjectively, there are ways that you can calculate the chemical shift ratio or the signal intensity index, and there are online calculators that can help you with this if you need to do this. This is an example. We see in the right adrenal gland, there's a small nodule that shows clear loss of signal on the out-of-phase image on your right, and this is consistent with a lipid-rich adenoma. So let's discuss some atypical imaging features of adrenal adenomas. Rarely, they can have a heterogeneous appearance, including cystic changes, necrosis, calcifications, or hemorrhage. This occurs in larger lesions. Rarely, they can also have small foci of macroscopic fat. We will discuss this in detail in a little bit. And what about growth? Well, it turns out that adenomas can grow. Roughly 1/3 of them grow. However, they grow quite slowly in general, on average about 1 millimeter a year, and should be less than 2 to 3 millimeters a year. So it's important to remember that atypical imaging features should raise suspicion for malignancy. However, given the high prevalence of adenomas, a nodule with these findings may still be an adenoma in the absence of risk factors for malignancy. And this is the classic saying that atypical features of common lesions may be more common than typical features of rare tumors.